Okay? If your classmates cannot join in because it's already full, because the room is full, please join the YouTube channel for the live discussion. Or if your internet is not capable to join Zoom, you may join the YouTube channel and hear the lecture. Okay? But as much as possible, well, it's better if you are in the Zoom meeting because you could interact better with your professors. Okay, I will leave you with Dr. Navarro. Um, okay, Dr. Navarro, you could take over.
Mute. I'm sorry, I was talking along. Okay, can you hear me now? Hello? Can you hear me? Hello? Can you hear me? Is there something wrong with... Hold on, hold on, hold on. Can you hear me? Can you hear me now? Yes? Yes? Okay. Okay. Sorry about that. I didn't realize it. Yes, Doc? Okay na po. Okay na. I see, I see. Okay, okay. Okay. Thank you. Okay, hold on. I just have to change the setting so you can also mute yourself. Okay. Hold on, huh? We're having some difficulties here. How to unmute all? Wait, wait, wait. Hold on. Give me a few minutes. I need to figure it out how to unmute it with the security. Okay, hold on. Unmute themselves. Okay. Can you try to unmute yourself now?
Yes, doctor.
Yes, doctor.
Yes, sir.
Yes, doctor.
Okay.
Yes, sir.
Yes.
Yes, sir.
Okay, okay.
Yes,
So
sir.
let's start again.
Yes, sir.
Okay, let's start again from the top. All right. Natural history.
Hello, sir.
हाँ फिर क्या सर ने क्या किया सर ने क्या
Guys,
किया ना सर ने मैसेज किया
Guys,
सर ने
please
हमको
mute
बोला कि ना
yourself.
सर ने अपना
Tavish, please mute yourself.
अनम्यूट किया फिर सर की आवाज हमको आने लगी
Please mute yourself,
Please
guys.
mute
हम
yourself.
क्या जवाब सर बोला
Tavish,
अनम्यूट
bro.
करो यार
Yourself.
Tavish, mute.
वापस 5 मिनट करा
Tavish, please mute
चला
yourself.
Tavish भावना मत वे भाई.
everyone, please mute yourself. Okay.
Please enable chat for everyone option also.
All right. All right. So, as I've said earlier, we would like to look into the progression of the disease. So, determine what are the factors of a disease causation, how does a man become ill, and what are the things that we also need to consider in also on the aspects of how are we going to prevent such occurrence of the diseases or illness. Okay, and as a doctor, it is also our job not just to cure but also determine how can the patient prevent such illnesses. So in epidemiological studies, natural history of the disease would refer to the progress of a disease process in an individual over time in the absence of intervention. Meaning, we just let him expose himself, without any intervention. And the process will actually begin with the exposure, accumulation. Adi Simran, whoever's doodling, please stop doing that. Okay? The process starts with the exposure or accumulation of such factors that would cause the disease. So without medical intervention, the process will be ending into recovery, disability, or even death. Okay? So Here you have an exposure, and you had the person who will allow himself to be exposed, or that's your host. And sometimes the host can also be the one providing ambient condition for him to develop such disease. And this disease will progress, whether it's recovery, disability, or even death. Okay? Who made this line? When you try to erase this line, ever done this line? You are disrupting the class. Anyway, the natural history of disease is actually getting the knowledge of the disease ranks that's alongside the causal or the causation, which is actually also an important aspect of your prevention and control. Okay? And understanding the natural history of disease is one major element of our descriptive epidemiology. So again, as I've mentioned earlier, no, even if you reach clerkship and internship, especially if you are actually exposed now to health centers, and you will understand the health programs and health practices on a certain community, you also have to remember, why does the patient develop such kind of illnesses? And what are the factors that causing my patient to become sick or ill? And basically, these are your natural history, because you can never have an effective health program or health control if, in fact, from the first place, you don't know how to prevent it, or you don't know what are the causes of such illnesses. Okay? So this is actually best described or best established by your cohort studies, meaning you have a subject and you have an exposure. So you want to know what will happen to my subject if I'm going to expose him. And that's basically a cohort study. No? And then you review it over time. No? The study sometimes can be costly, expensive, and understanding the natural history of the disease is based on epidemiological studies, such as your cross-sectional, retrospective, which is actually undertaken in different population settings. So the physician in the hospital will actually just have a look on the episode. He is not basically looking into the bigger picture of the disease entity. So if, for example, a patient came in due to cough and colds, he might be just seeing this person 1 or 2 cases in a day, no? And then now you will try to suspect, why is this patient coming back, and why are these patients are actually coming from the same area? Am I actually having a large cases of this because of transmission? No? So that physician or doctor would try now to investigate further. What causes this cough and colds in this particular area on a particular population alone? No? So the epidemiologist, by studying the natural history of the disease in a community setting, no, will actually able to fulfill the gap in the knowledge of that natural history of the disease. So basically, if you are going to study epidemiology, we're not just dealing with numbers. These numbers or these tools will only help us to understand further. No, to understand further. Can you please stop doodling? Because it actually affects now the screen. I could see now 2 lines. And there's no way I could erase it. Aditya Kumar, why do you... Okay, there's something wrong with our security with this doodling thing. Please refrain from doing anything except listen and then watch. Okay, the natural history and the spectrum of the disease would present some challenges to the clinician and to the public health worker. Okay? The clinician or the physician in the hospital may become overwhelmed if that doctor or if that health workers will not be able to determine what usually the causing of the disease. No? And this is what actually happening now in our current situation. No? The clinicians, maybe they are in the clinics or in the hospital, will have also need to investigate what happened to the COVID, and they need also to investigate what is the natural history of COVID. No? And by doing so, he will probably able to manage the patient, but prior to management, he has also need to know how can we able to prevent its transmission. Okay, because of the clinical spectrum, the cases of illnesses diagnosed in the community would often present as only the tip of the iceberg, no? And many additional cases can be too early to diagnose. Go look at screen. Wow. What is happening now to my slides? Why there are a lot of googling? Okay, let me just stop it for a while.
So you can check their names under the scribbling and we'll write their names
Yes.
down and remove them from the group.
Yes, I've seen some names. And
Can you
if you
please
see
tell
some
me
names, please take down the names.
Yes, I'll do
And
that.
if you keep on doing and that, they keep on interrupting the class.
Okay.
And then we're going to remove them. Okay, LO, please take note of that.
Yes, I'll do that right now.
LO, you have the power to take them out, boot them out. Okay? Okay, we're talking about the iceberg concept of the disease. We are looking only at the tip of the iceberg. So, meaning, if you have presented with the death of a person or maybe a group of people in a certain area, say 10 persons died in one particular episode, in one particular area, you might probably think, what causes the disease with the same symptoms, with the same manifestation? Could this be a severe disease that can be transmittable to a lot of persons? Or could this be just a mild disease, no, that would actually able to become a severe one? Dr. Audrey, hold on. Now I stop sharing my screen. I need to
Screen not available.
Yeah. Hold on. I still have to get permission from Dr. Audrey. Okay, wait. Okay.
Hinahanap ko kung paano tanggalin yung nagsusulat-sulat.
Yung doodling, ma'am.
Sige na,
Okay.
sige. Sorry.
So, the iceberg concept, if you are presented with the death of some individuals, you might also want to know the severity of that disease or how fatal the disease itself and how many patients are going to die, are going to expose this disease. And then again, a very relevant example would be your COVID. COVID is highly transmissible, and some COVID can proceed to death or can lead to death because of the severity of the disease itself. No? So that's precisely the reason why we advocate the vaccination, because we don't want our patients to progress into severe disease which could lead to death. Okay, so if you have an exposure but without infection, no, that's going to be the first line. No, you have an exposure, but I don't have an infection. But however, if there's going to be infection, and this time, no, I become infected, but again, I don't have some symptoms. So this would be your subclinical disease. I have exposure, I'm not infected. So for example, tuberculosis. I might be exposed to some tuberculosis, to tuberculite, to the microorganism, but I'm not infected. And some people may also be infected with this disease, but they don't see any clinical manifestations. So these two can also be carriers of that disease, right? And that's gonna be also our problem because patients with the COVID sometimes can presenting to be asymptomatic without any symptoms. No, we would presume that the patient might be a COVID negative unless proven otherwise. If you're going to conduct or do a COVID testing, wherein you can confirm if it's a positive or negative. And that's precisely also the reason why, as clinicians, whether you are
Excuse me,
presented
doctor.
with colds, whether you're presented with flu-like symptoms, we would treat them or we would see them as a COVID suspect, no? We would see them as a COVID potential or a potential patient of having the COVID, okay? Because primarily they present almost the same symptoms. The usual cough and colds or flu would also present what? COVID symptoms, okay? And that actually makes this our situation a very, very crucial, okay, and very, very tricky because of this dilemma. So if you have the infection without clinical illness or exposure without the infection, this is considered a subclinical disease. But if the symptoms would appear, whether it's mild, severe, or death, this is now your clinical disease. Okay, let's talk about the model of the disease causation. Okay, we have germ theory, epidemiological triad, epidemiological tetrad, the beings theory, the web of causation, and the Wells theory. So let's discuss this one by one. Okay. Let's start with the germ theory. Okay, I always remember when I was a child, no, you would often hear mothers would tell the child, "Hey, stop doing that! Don't touch it! It's too dirty! Don't put your hands in your mouth! It's dirty!" We will often hear that, right? And primarily, that is actually the germ theory. Even our mothers knows about the germ theory. And this is proposed by Robert Cox and Louis Pasteur, no? Every human disease is actually caused by a microbe or a germ. Before, they didn't even actually know what particular microbes or organism it could actually cause, which is can be also specific to that particular disease, and one must be able to isolate a microbe from that diseased human beings. Okay, can you still hear me so far so good, guys?
Yes, doctor.
Yes, doctor.
All right. Okay. If I cannot see your chat for some reasons, LO, try to message me in the Viber in a way that I could see my phone. Try to reach me in the Viber, okay?
Okay.
Then I'm going to check it from time to time. If I could not see
I
the
can't hear your voice, doctor, properly.
huh?
Your voice is not coming properly, doctor.
Voice.
Yeah.
Okay, I'm sorry, but we need to just adjust with the connection because I'm also in a remote area like you. Okay, but so far most of you can still hear me, right?
Yeah, doctor.
Okay,
Yeah, doctor.
so basically that is your germ theory. Microbes or germ can cause the disease, but we're not very particular with specific, whether it's a bacteria, virus, or parasite. But basically, a germ or a microbe will actually cause the disease. Now, what is the epidemiological triad? In here, see that you have an agent and you have a host. Okay, the agent is the one that causing the disease, and the host is the one harboring, or actually sometimes also provide a conducive environment. So if you are actually a balance between the host and an agent, and there's going to be imbalance between the two, and they could actually able to progress the disease. Say, for example, do you know that we have our resident bacteria in our body? In fact, billions or billions of bacteria are residing in our body, which is actually are considered normal. Yes, Lakshmi, Sravani, you raise your hand. Yes, Lakshmi, would you like to say something?
Sorry, doctor, it's by mistake.
Okay, all right. At least we can interact with each other. It's fine. Okay. So if there's going to be too much of these microbes, that will also affect the balance in our body, and our body is considered is as actually a biosystem. No, our body is supposed to be all in a balance, and if it's going to have a dip in that balance, you will able to see the effect
Why is your video
on that
falling?
particular area.
Look at my setup.
Rohan, Jonathan, please mute yourself. Okay. Now, when you talk about epidemiological, okay, when we talk about our agent, we would like to also know that agents can be an element or a substance, whether it's an animate, it's moving or non-moving, in the presence or absence of this agent would actually initiate or perpetuate the disease process. So for example, the dust itself, the dust particles are still also considered an agent, and they are not living things. But still, these are agents. If the dust would dislodge now into your nostrils and into lungs, and then it will accumulate over time, then obviously you would actually able to, obviously you will have a progress in the disease, no? A disease can have a single or a number of independent alternative agents, or it can be also a complex of the two or more factors. Okay, so you can have a lot of factors that can contribute to the progression of that particular disease. And again, it could be a single or it could be a multiple agents. So what are the agents that we know can be classified into the following? Biological, it can be nutrient, no? It can be a physical agent, a chemical or mechanical, or an absence or efficiency of a certain factor that determines the health, and even the social factors, no? And this is what we call the model of biopsychosocial model, no? That our body responds to certain elements of our, also not just the environment, but also our internal environment, no? So the agent would have the following characteristics. Ineffectivity refers to the proportion of the exposed person who become infected. When you talk about pathogenicity, this is the proportion of the infected person who will develop the disease or the clinical or shows the signs and symptoms. No? When you talk about virulence, this is the proportion of that person with clinical disease who will be severe eventually or die. So we talk about how actually the strength of that particular agent to make the person or to make the patient die or severe. And these are the following examples. No? Hep A virus in children has actually a low pathogenicity, meaning they will not show right away signs and symptoms, and they have a low virulence, meaning patients having Hep A will also infect our children, but they will remain symptom-free or can only develop mild to moderate mild to moderate illnesses. Okay? In patients with good nutrition and health, the measles virus will actually have, spite of this good nutrition, the virus will have low or high pathogenicity but low virulence, meaning it has the potential to develop clinical symptoms but can be mild to moderate again. since almost all infected persons will develop the characteristics of the rashes and illnesses, but only few will develop complications, such as your pneumonia or encephalitis. So, you would also have to explain to our patient the virulence and pathogenicity in a way that you will understand the importance of following such health education practices or health practices. Okay? In person with poor and health, measles become more virulent with the mortality of 5 to 10%. So basically, these two scenario can also tells you about their social, economic status of your patient. No, you would expect patients to see in a poor urban setting that has a poor nutritional and health status, and these patients coming from this family will actually have a high death rate compared to those who are well off or well nourished, no, children. Okay. Another example would be your virus, the rabies virus, which is highly pathogenic and highly virulent, and virtually almost 100% of these infected individuals will actually lead to clinical disease and death. Okay? Okay, let's talk about again now the host. Epidemiological terminology, the host is the one considered to be the soil, and the disease agent is the seed. So for the seed to progress into a plant or a flower, then the soil has to have the ambient or the enough nutrients for the agent to prosper or to grow into a plant. So consider yourself the individuals, humans, animals. These are the hosts. Okay, the person or other living animals will actually provide subsistence or lodgement to that infectious agent under natural conditions. And the host factors can be intrinsic or extrinsic. When you talk about intrinsic factors, these are the factors that would influence the individual's exposure, susceptibility, or response to the causative agent. So you have two factors on the host. You have your intrinsic and your extrinsic factors as well. Okay? So when we talk about environment, we're not just talking about here the physical environment, the water, the soil, the heat or the light. We're also talking about biological exposures and psychosocial environment of that particular individual. Okay? So for example, how come still our patient is having this disease despite of patient living in a well-off family with a patient can able to get all the things that he wanted to, but something inside him also affect his lifestyle and also have probably his mental health. The person may be also under stress. Yes, he has a lot of money. Okay, he buy a lot of things, material things, but still is not happy. Or probably he are also exposing himself to a lot of substances that can lead to progression of the disease. Okay, so that's your psychosocial or social environment, affecting not just a patient's perception about himself, but also the way he interacts to his environment or to others. As they say, if you notice, stress can actually be in two types. You can also have a positive stress or a negative stress. Okay, some persons can live off with stress and they actually become more productive. They are happy because these are happy stress for them. But there are people who becomes very stressful despite of all of these things because this stress can be on the negative spectrum, on the negative side. Okay? So you have a long and a long also being infected by much of your diseases that transmitted by inhalation or even droplets.
Sorry to disturb you, doctor. Your screen is not clearly visible.
Come again?
The screen is not clearly visible.
The screen.
Yes, sir.
Okay. How about now? Can you see my screen now?
Yes, sir.
Yes, doctor.
Yes. Okay.
Thank you.
So thank you for calling my attention. Okay. In TETRAD, we are talking about 4 aspects now. We also have to consider the time of the exposure or the time the host or the agent or the environment interface with one another. Okay, because some patients or some hosts can be only exposed in a short period of time with a very detrimental effect. Okay, but over the years, some patients or hosts can be exposed over time unknowingly. No, he is actually developing the disease itself, but it usually takes a lot of time. For example, cigarette smoking. No? Cigarette smoking will take its toll years and years after smoking. No? This is actually accumulation of all these chemicals that would induce the disease, particularly in the respiratory system. No? Over the time, patients are actually exposed to these harmful substances. So that's why we consider now time as an essential, okay? It's an essential factor in the disease progression. So disease occurrence, different diseases with a different communities with also different type of group of people will actually show different patterns of occurrence. When you talk about occurrence, okay, how the disease is actually occurring or affecting a community. Okay, so some terminologies that you need to or definitions that you need to understand at this point. When we talk about endemic, this is habitual presence of the disease. Can someone please tell your classmate to mute? Hearing a lot of noise in the background.
Yes, I'm
Whoever
telling it
is,
right now.
thank you. When you talk about endemic, this disease is present in that particular region or area or geographic area. Okay, you would agree with me that most of parts of India, you will actually know that this specific area is endemic of specific illness or specific disease, probably because of their geographical location or geographical features. What would you expect in some region in India that are living in mountainous area? What disease could we expect that this can be an endemic on that area? Give me an example.
Sorry, doctor. I am sorry to interrupt. Can you please ask the question again? I was not able to hear it because of the audio problem.
Yes. Could
Can
you
you
give me
please?
an example of a disease which is endemic in India and give me the geographical condition?
Elephantiasis.
Okay, very good. Elephantiasis. Okay, can you give me
Chikungunya.
a specific area in India which is endemic
Malaria.
elephantiasis?
Malaria, doctor.
Chikungunya.
Tuberculosis, sir. Tuberculosis.
Yes, malaria.
Malaria.
What
Malaria
is
is
it?
endemic in what part of India? In what part of geographical area?
Like in the
Japanese encephalitis. Outside.
Okay, let's talk about first the malaria.
yeah,
Malaria
sir.
is endemic.
Yeah,
In
yeah.
which, in which geographical area in India? Where in India it's actually considered endemic?
Mountains, range, mountain range.
Like most in the place where a lot of water is present, so the mosquitoes can
Stagnant
Yeah.
water, not flowing water.
stagnant water.
Stagnant
Sorry.
water.
So
Kerala.
usually slum regions.
Yes,
Slum
that's
region,
right. Also,
insanity
I've heard
Dengue
places.
fever also endemic to India.
yes, I've also heard the mountainous area. Okay, that's correct. Now, hyperendemic. Okay, this is highly or persistently high level of occurrence. Okay, you have your endemic and highly or persistently high. Sporadic, these are isolated or irregular pattern of occurrence, normally occurring in occasional cases with irregular intervals. Okay? These cases can be rampant or would not be on a certain particular time of the year. So sporadic, it's irregular pattern. Okay. Epidemic. When you talk about epidemic, occurrence in a community or region with excess of normal expectancy. Okay? Say for example, you have a lot of cases of dengue during the rainy season. Okay? And as expected, no, you would see a lot of cases, say for example, in Laguna. We are seeing hundred thousands. Okay? When do you consider that this is going to be an epidemic or an outbreak? If beyond 100,000 has being now reported, comparing the previous year. Okay? So for example, no, in 2010, there were reported 50,000 cases of dengue. And then suddenly in 2012, it becomes 300,000. Okay, you can now actually refer them as epidemic or there is going to be an outbreak, which is practically the same. You will only say that there's going to be an outbreak if you are able to compare the occurrence of such disease with different time. Okay? So when epidemics spread over several countries or continents, just like your COVID, affecting large number of people, this is what we call now your pandemic or your worldwide epidemic. Another example of pandemic which affects most of the countries except your COVID. Would you think of other disease that is actually considered a pandemic?
Sir, Ebola.
No,
That's
Ebola is not considered a pandemic.
HIV.
Spanish flu.
influenza.
Okay, very good.
Influenza.
Yeah,
Spanish
yeah,
flu.
Swine flu or bird flu?
HIV. HIV AIDS is considered also a
Polio.
pandemic
Polio.
problem.
Spanish flu.
Swine flu,
Ah.
swine flu.
Oh, okay. Thank you for the answers. Okay, but answer that I would like to hear would be your HIV/AIDS. Okay, let's talk about now the beings models of disease causation. It's actually acronym for the following. No, the concept postulates that the human disease, are caused by a complex interplay of different factors. Okay. So these are the following. Biological factors, behavioral factors, environmental, immunological, educational factors, genetics, social, spiritual, and services factor. Why would you include spiritual this time? Because certain beliefs and practices can also affect disease causation, right? Netaji, Srinivasan, why would you include now spiritual factor? Netaji,
No, sir.
Srinivasan.
My mistake, sir. Mistakes. My mistake.
Okay. Spiritual factor can also interfere with the management of the patient. How are we going to manage them clinically? Some spiritual or religion would in fact prohibit blood transfusion, no? At on that level of clinical management. But even the disease causation, some of the practices or religious practices exposing them to different kind of agents. That's why we consider spiritual factor as one of the model or factors that can contribute to that disease causation. Epidemiological triad was effectively used by Liddell and Clark in explaining the natural history. Okay, but it could not explain the causation of non-communicable diseases such as your heart diseases or even the road accidents. And that's why the web causation was formulated. It was McMahon and Pugh forwarded the theory of epidemiological web of causation, wherein other various factors such as hypercholesterolemia, smoking, hypertension are also interacting like a web of a spider. So each factor has its own relative importance in causing the final departure from the state of health. This is your web causation. Okay. The problem here is actually obesity. Guys, obesity is considered to be a public health issue or concern because as we also understand, obesity contributes to a lot of disease or illnesses progression. Obesity could lead to hardening of the arteries that eventually could lead to stroke. No? And obesity are actually caused by certain factors such as it could be hormonal or familial. No, it could be stress. The diet is also is also a factor, and also physical activity. If the patient is sedentary or inactive, then the patient becomes obese. Now, if this obesity is actually still inherited, no, then that patient can now, the patient will actually develop irregularities in the blood clotting mechanism, auto hypertension, and hypertensive disease. Okay, so this is an example of the web causation. Another cause or another representation of your web causation would be development of your tuberculosis. So you have a susceptible host, and that susceptible host lives in an area where there is a overcrowding. As we know of, the Mycobacterium tuberculosis will easily be transmitted through droplet. No? And if the person is malnourished, meaning his immune system also is very low, and if the patient has no protection, the patient is not vaccinated, no, then that person can have an exposure to mycobacterium and leads to your infection. And once there's a tissue invasion and reaction, the development of your tuberculosis. So you have your epidemiological triad, which is used or devised to enhance the search for understanding communicable disease, and your web causation will now address both the non-communicable diseases and also your communicable diseases. Okay? When you talk about the wheel theory, this visualizes human disease in a form of a wheel. The center hub in the center represents the genetic components of that particular peripheral portion. So like a wheel, there is outer component, the inner component, and the area wherein you'll have the interplay. No? So the outer component is your environmental component. Okay, and the environmental component is also divided into 3 subcomponents representing your social, biological, and your physical. Okay. So what are the factors of disease causation? Okay, when you talk about certain factors, we have to be very particular of the factors. Okay. Predisposing factors, these are the factors that would create susceptibility. For example, the age group, the gender, and the previous illness. Okay? On this particular age group, we are susceptible to develop such illnesses because of maybe one factors. Say, for example, the age group of 40 to 45. What is the susceptibility or what is the predisposing factor of this age group that they will develop lung disease? It's likely very high because they have already exposed themselves to certain harmful substances because they are already on that age group. What else? Age group of 40 and 45.
Hypertension.
Yes, very good. Hypertension. They are very prone to hypertension because they are experiencing a lot of responsibilities and a lot of stress. What else?
As well as diabetes,
Yes, lifestyle
thyroid
diseases such
problem,
as the
liver
diabetes.
functioning, kidney functioning, etc.
Yes, that's right. Even
Kidney
diabetes
related problems, thyroid,
and cancer. So these are the
TSH, FSH, hormone.
okay, thank you. So these are your predisposing factors. Enabling factors, this will help in the development of the disease or even the recovery of that person. So if he has a very good condition, a good housing condition, or a good socioeconomic status, this can also affect or help the individual to recover, or worse, or become the condition worse. Precipitating factor are associated with immediate exposure, no? Such as drinking contaminated water, precipitating or close contact with a person with tuberculosis. Reinforcing factor will aggravate or make the condition worse. Risk factor, and these are the probability the patient could have, no? It could be a condition or quality or attribute that would increase the chances of that individual to develop such disease. Okay, so for example, here you have exposure to tuberculosis. If you are exposed to tuberculosis, majority will not have the infection. Some would have the infection. And these infected individuals will be considered a latent TB, which is 90% of this, will never develop the TB and not considered as infectious anymore. However, 10% of this infected individual will develop tuberculosis in 2 years. If these are not treated, they will die. 50% of them will die in 5 years. And if it's going to be treated, will be cured. Okay, that is your tuberculosis exposure. Okay. So we talk about the preclinical and the clinical phase. We're in the onset of the disease, the pathologic evidence of the disease, the occurrence of the signs and symptoms. So that is your clinical. And once the signs and symptoms would come in, no, you have now your clinical phase, wherein medical treatment is being sought, diagnosis and treatment. So we want to focus on the, yes, TV, Shankar, you raise your hand again.
Yeah. Yes, sir. Actually, my question is that if the disease is spread by the animals, which are there, we can develop dog, cat, etc., etc. Then which factor we will call that up?
Secretary, please hold your questions. We will answer that later on because sometimes the audio is not that very clear. So let's park all the questions later on. Okay? All right. So we want to focus on the preclinical phase because this is where we would like to help our patient not to go to its severity and in fact not to become sick at all. Okay? Because in here, if we were able to determine the factors that can lead them to develop the disease, then the patient will become or eventually become healthy, right? Because we want to make our patients healthy. Absence of no disease is considered healthy, right? So before the man is being involved, no, you have your interplay of your three factors, your agent, host, and environment, no, which will bring now to your triggering of the stimulus. So this is your pre-pathogenic period. Once the stimulus is triggered in the human, the stimulus or the agent would be increase its multiplication, would increase and increase, and the interaction of that host and the stimulus will actually going to progress or changes in the tissue or the body composition or anatomical composition. Okay? If there's going to be an interplay and if they're going to have a change in your physiological and anatomical, then there would be occurrence of your signs and symptoms. So you want to investigate on this level because you want also to know what causes the disease of why the patient had the disease or the illness. So in pre-pathogenous period, this is where the man, before the man is being involved, and in the period of pathogenesis, this is your early pathogenesis, discernible early lesions, wherein you could see some signs and symptoms, and then if that would progress to illness, and that is your advanced disease, to disability, death, or chronic, and then death again, no? Okay? Disability can lead to recovery or death. Okay? So this is the period wherein we want to see what would like to have our intervention. How are we going to provide or how are we going to answer the problem of your patient on this particular level? Okay? So this is the schematic diagram of stages of infection in a host. No? So you have an infected individual, infection patient, wherein you could have patient with from the period of communicability, wherein the patient is able to transmit the diseases, and that total period of infection, wherein the agent is present and the agent is being shed off, and that area is considered the patient is to be infectious. No? The patient is infected and the agent is being shed off, and the disease in the host is also manifested. However, sometimes the patient might be infected but not contagious anymore. Okay, why is that so? Because the agent is being shed off already. And the patient can just be a carrier. No? So looking at this, an interplay on the agent host and the environment, you would notice that in the pre-pathogenesis period, we want intervention on the following: health promotion and specific protection. Okay, what is health promotion? What comprises your health promotion? Health promotion comprises educating our patients. So this is a good standard of nutrition, providing um, adequate nutrition and providing also good aspects of personal hygiene, adequate housing, recreation, and good or agreeable working condition. Even patients can also have a counseling on the genetics. Some genetics can be corrected as well. You can also provide some counseling. And This is also a periodic examination wherein you would see or monitor the patient. If the patient is actually prone to develop such illness, because you want to monitor, and periodically there is a periodic surveillance, no, of your patient. And that's primarily the reason why we subject our patients or workers in their annual physical examination, because we want to know even before the start of the disease if that person will actually develop such condition. So health promotion and specific protection is under your primary prevention, and that is the first level of the disease. First level of prevention, sorry. Okay, so that is under your pre-pathogenesis period. And another component of your primary prevention is your specific protection. What is the specific protection? Use of a specific tool or measures to prevent such illness, just as your immunization. Immunization, you want to prevent a specific illness, right? Or it could be also attention to personal hygiene, no? Because certain diseases can be attributed to poor hygiene, use of environmental sanitation, protection against occupational hazard, because you already determined what type of what illness or disease would patient would have if you are also going to make that patient exposed to. Let me just check the chat room. Okay, Kartiri, I have a lot of things to said here. Okay, very good. Okay. That comprises your primary level of prevention. Okay. When you talk about interaction of the host to the stimulus, this time it's just the host to the stimulus, and there is now progression of the pathogenesis, no? Meaning they might also have occurrence of the signs and symptoms, or the patient already have the disease, or the patient have the disease but you want it to or prevent it to have disability or complications. If you're talking about secondary prevention, you are now talking about early diagnosis and prompt treatment. Okay? This time, this would include your case finding measures or individual or even in the mass. This is the screening, no? Screening survey. You want to know already the disease, who have the disease themselves. The objectives of the early diagnosis treatment is to cure and prevent the disease itself. Because you don't want it to progress, or you don't want the person to be infected to another person, to prevent its spread and to shorten also the disability. Okay? Secondary prevention will also comprise of disability limitation. When we talk about disability limitation, providing facilities to limit disability or even prevention of death. And tertiary prevention is provision of hospital or community facility to retain and educate to educate the public or the people on how are you going to help that individual to back to almost near normal. Okay, so this also includes full employment if possible. Okay, for that individual. So again, let me reiterate this slide because this is very important. Primary prevention, have your health promotion and specific protection. Secondary prevention, you have your early diagnosis and prompt treatment and disability limitation. And your tertiary prevention is rehabilitation. I have already stated examples of such programs. Okay? So if you are devising a public health approach, or how are you going to address such public health concerns, First is you need to determine what's the problem of my community. So that's why you conduct also some surveillance. You investigate further, and then you try also to identify what are the risk factors that actually uh, exposing my patients to such illnesses. And then if you now are able to identify what would be my intervention or evaluation, how it does work, what would work for my community, and how are we going to implement it. Okay? So going back to our community, no, at some point you are also required to immerse yourself. When you say immerse, you live along by the people. You will eat whatever they eat. You will breathe the same fresh air that they have. You will drink the same fresh water that they have. There are certain immersion in the community, because if you're not going to immerse yourself to that particular community, you will never understand what's actually going on to the people. Okay? Before, when I was still in the medical school, we were actually immersing to our community. We're staying there for a month or two, no, understanding the dynamics of the community, no, understanding their culture, understanding their behavior, no, knowing the people, talking to the people, no. So you can never really understand a particular area or know the particular community unless you live with them. Okay? Okay. So what is this primordial prevention? When you talk about primordial prevention, this is prevention of the emergence or development of the risk factor. So this is actually in fact more earlier than the primary prevention. Okay? Example, many adult health problems such as obesity can actually be attributed to the early origins in the childhood because of their lifestyle have already formed. So I usually tell this also to the parents. If you're going to allow your child to eat whatever the food he wants to eat, you're the one who's going to be blamed for all illnesses that you're going to have in the future. Okay? I always tell the parents, you're the one to be blamed. This child would eventually develop cardiovascular diseases or diabetes. If you're not going to impose such discipline, that kid will suffer eventually. Okay? So this is also our effort to encourage our families, especially the parents, no, to discourage them, their children, from adopting harmful lifestyles, because this was already developed among themselves. No, if that child was able to expose to a healthy lifestyle, eating vegetables and fruits, limiting the use of gadgets at the only particular time, no, it is already his in the system. The main intervention here is to make it more individualized and eventually mass education. Okay. Primary prevention, as I mentioned a while ago, it has two sub-steps. You have your health promotion and specific protection. Health promotion steps under to improve the level of the general health. Okay. Primary prevention would include what? Overall socioeconomic status of the population. You can never treat all the patients right away if you could never understand where is the water supply is coming from. If there's enough drinking water, is this enough lighting or electricity? Is this actually enough food supply? So health education, promotion of the breastfeeding, promotion of small family farms, educating, and motivation for a healthier lifestyle. And that is your primary prevention. Primary prevention is actually a preventive strategy. However, health promotion approach will improve the general health. For example, by promoting breastfeeding among children, we also try to prevent general malnutrition. On the other hand, when condom is used, it is very specific to certain specific diseases, right? When a measles vaccine is given, only a specific disease. So this is your specific protection. Okay, so your primary prevention will have population strategy or your high risk strategy. When you talk about your population strategy, okay, you would like to see larger potential of the population, okay? And the advantage here is will be small benefits on the individual, okay? When you compare it with your high risk strategy, it is more appropriate to individual, and you need to motivate that particular individual or even the physician, but it would actually cost a lot of money and would have only temporary effects. Let me just stop sharing so I can remove that doodling again. However, there are certain illnesses or diseases wherein there would be approach to the population, or if you need to approach with a high-risk strategy, depending on its severity or depending on its gravity of the problem of the disease. No? A preventive measure will bring much benefit to the population if often offers little to each participating individual. Okay? Example is the Framingham study wherein the data suggests that if all men up to age 55 will reduce cholesterol level by 10%, 1 in 50 could actually avoid heart attack on an average. Yet, however, 49 of the 50 would follow the same measures and perhaps not getting out of it. Okay? Secondary prevention would now include actions at the early stage of the pathogenesis, with a view to halt or prevent the disease in the earliest time. So early diagnosis and prompt treatment. A classical example would be your screening for the disease. Even without disease, you would assume the patient had. So secondary prevention for breast cancer would include mammography. For cervical cancer would include your pap smear, because you want to screen, and then once you detect it, you treat it right away. Medical examination among school children and also industrial workers are also example of your secondary prevention. Tertiary prevention, as I said, there are two types: disability limitation and your rehabilitation. Okay, so disability and rehabilitation. The sequence of that disease would turn into handicap. The disease itself, the pathological process, impairment, the actual loss or damage of part of the body. When you talk about disability, this is defined as inability to carry out certain function. And handicap, this is a final disadvantage in life, wherein the patient consequently limits the fulfillment of a role. So rehabilitation is actually the second component of your tertiary. The first is your disability limitation. Okay? Disability limitation by providing your faster cast or complete bed rest or providing oxygen to prevent or given to our patient with MI to prevent death or complications. So that's your disability limitation. Okay? So again, levels of prevention, including also your primordial. Here, the phase of the disease is underlying condition, addressing underlying condition that leads to causation. The target group here is the total population and some selected patients or groups. Primary, specific causal, we already identified. Okay, the target would be population and selected group or healthy individuals. Even the healthy individuals are also included here. Secondary and tertiary, okay? Secondary is the early stage of the disease. In fact, you already know patients, no? And tertiary, the late stage of disease and addressing your patients. The stage of positive health is a balance between the three factors. If there's going to be imbalance, as I mentioned, you have your specific protection. So your aim or your goal in the health promotion is to have a balance, no? And the specific protection is you somehow able to see what could be taken up, no? What could be addressed to, since the factor is already disturbed, no? In secondary prevention, you have your early diagnosis and prompt treatment. You already have the pathological process have started. So detection is the only possible way to specify or investigate an early discernible disease. There's already the disease itself, but mild, no, to moderate. And then now you have your full-fledged and your rehabilitation. Okay, it's a very good able to differentiate all of the levels. So you have your primary health promotion and specific promotion, secondary early diagnosis from treatment, and then tertiary disability limitation and rehabilitation. As you can see here, there is an overlap between secondary prevention and tertiary. If the disease itself, you can still do something about the disease, no, on the early stage, and that you can also limit this disability, and that would still also consider the tertiary prevention. So quantifying the prognosis, when you talk about prognosis, this is quantifying the likelihood of a specific outcome or survival. Doctor, for how long am I going to live? Can you tell me in a 5-year span? No? What is the prognosis of this disease? When you hear the word prognosis, for how long am I going to survive this? Am I going to die very soon? If, for example, pancreatic cancer is known to have to be a bad prognosis, with a bad prognosis, because most of these patients would die in a span of months. No? Sometimes it could persist only for 3, 4, 5, 6 months, not even a year sometimes. Huh? So if you have a prognosis that is actually bad, you were actually looking into the death or survival. So you have your 5-year survival, observed survival, median and relative survival. Okay? But then you can also see what are the things patients or things to be done to our patient. Whether the patients need to be treated, curative, or on just on the palliative, or in just on the support. We're not going to treat the patient anymore. We're just going to support him or alleviate the suffering or lessen the pain or lessen, or should I say, help the individual or the patient die gracefully. It's just a palliative phase. Okay. Case fatality rate, fatality is, are you going to compute it? You divide the number of people who die of the disease and the number of people who have the disease. For example, if most of these patients were going to die, 200, all of the patients, the 200 and the death, 20, or 200 people has the disease, and 20 has
Doctor, it's going very
die.
noisy.
It's very noisy at the background. So the
Yes,
case
doctor.
fatality here is 10%. With the COVID, would you predict how much or what is the case fatality rate of the COVID? You could see still, that's still a lot of people still die, but the case fatality rate of your COVID would be less than 3 or 4%. Okay. So what's five-year survival is the proportion of the patient who are actually alive in a span of 5 years. So the number of persons with specified disease surviving 5 years over the total number of persons with the specified disease. So So the disease onset, okay, he was diagnosed in 2005, and then the development, the disease over the time of the year, and then was completely diagnosed and treated in this period of time. So you would see the prognosis. So widely used in cancer studies, okay, the 5-year survival rate in women is the stage 1 breast cancer, which is only localized. The breast cancer, the survival is around 88%, whereas it actually lower if the stage of the cancer would be on the 4 or metastatic of already spread in the lymph nodes or other organs. No? The prognosis or the survival rate will be actually decreased to 15% only. The lead time is the time between the early detection of the disease, where it's your screening, and the time of its unusual or usual clinical diagnosis would appear. So the lead time bias occurs because the failure to account for the lead time while calculating the survival. Okay? Observed survival rate is the estimate of your probability of surviving. Probability of surviving can be also calculated using the technique of the life table analysis. Median survival is the length of time half of the study population will survive. Relative survival is the ratio of that observed survival rate to the expected survival rate. For example, you compare the survival in a study group, for example, the cancer, to the survival of a comparable group without the disease of interest. Okay? So it will remove from the observed survival the effect of death from all other cases. Okay? So, this afternoon, in a nutshell, you're able to understand now the causation of the disease and what is the progression of the disease into different stages and where does the interventions comes into play, no? You can also understood very well what are the factors that causing the disease to progress and what are the factors also that would help a patient not to progress into the disease or illness. Okay? You also learn this afternoon the levels of prevention because you can never understood levels of prevention without understanding the nature of the disease causation. Right? So, understanding both of the concept, you would know now why is it important for this patient to be informed about certain condition and be informed about certain intervention. And this is our job as a physician, whether whatever subspecialty you'll be into, whatever setting you'll be into, you also have to primarily you also have to have your basic knowledge or basic foundation on this concepts. Okay? That's why you'll be taught on the anatomy, biochemistry, physiology, and then later on you'll be taught about the microbiology, parasitology, before you being taught of the interventions or pharmacology. You should know what would be the factors that will interplay in the progression before you can manage them correctly. Okay? And we also want to tell you that not all of the patients need to be seen in hospital. Okay? Not all the patients, in fact, will develop into severe condition if you have the proper mindset and if you're able to provide the proper mindset to our patients. Okay?
Okay.
Okay, everyone. So I guess we're able to answer some
Sir,
of
who
the questions in your mind.
sir, who will teach us biostatistics? It will be included in PMCH only, or we need to follow another subject?
I'll just wait for some announcement regards to that. Okay.
Okay, doctor.
All right.
It's me, doctor. You mentioned something about clinical spectrum of disease. What does that exactly mean? Like, what do you mean by clinical spectrum of the disease?
Clinical spectrum?
Yes, sir.
Yeah, we're basically talking about the whole picture of the disease. When you talk about clinical spectrum, you're not just dealing with the symptoms, with your management, but the entire picture of the disease. Okay, you also want to know what are the cause, what causing the disease. You also want to know what would be the progression of the disease. That's the clinical spectrum. Okay, not just focus only on the disease itself, but focus also on how are you going to that disease was able to prevented of that disease will progress into something more serious one. Okay. Some of the patients would go to you, doctor, am I going to die? Will it be, am I going to survive? Or can you please tell me how much percentage am I? Sometimes it's very difficult to answer those questions without really realizing disease or without realizing the nature of that disease itself. So which book are we going to follow? References will be given to you, Sir Andres. Okay. And before you can actually answer all of these questions by your patients, you need to also understand or study carefully the illness and what are the factors that interplays with that illness. Okay. And it's very difficult to quantify it right away if you actually don't understand the disease progression itself. But sometimes you can easily say about its survival is one, based on the experience of that particular doctor, and two, based on the previous cases that have been documented. Okay? Because certain cases would also have the different approaches. Okay? So just at this level, just focus on the preventive aspects, let's focus on understanding the interplay of all of these factors and understand the causation. And then once you reach again health programs, applications, you will always throw these questions back to you. What are the hosts? What are the agents? And how the environment or factors interplay with one another. Okay? So don't treat the person as just one person itself or one disease itself. You have to treat the person as a whole being. And what are the factors affecting that person? Imagine, no? Person is not just one disease itself. It's two, T. No. Look at the person as a person being, not as a patient or just a disease entity. Okay? All right. So I guess, Dr. Andres, I think we're done now. Dr. Andres.
Sir, what is difference between clinical disease and subclinical disease?
Oh, it was already discussed, clinical and subclinical. Anybody?
Sir, I want to speak about it. Like in clinical disease, we can see symptoms, but in subclinical disease, we are not able to see symptoms. Is it right?
Yes, it could be. Yeah, that you're correct. Subclinical, okay, even the patients will not have actually the symptoms. But in the clinical, it starts now to suspect because patient is feeling something that is wrong with him.
Okay, sir.
Okay. Thank you, Dr. Navarro.
Thank you po.
Statistics will be tackled on the second semester. So, don't think about it just yet. Okay, and request, please change your handle into your names because when we look at the attendance after this recording, it's hard. For example, 806421. How
Who
would
is
we know
this?
who that was? So please, next time that you attend class, make sure that your handle, you change it into your enrolled name. All right? So we'll see you next Thursday for another lecture on PrevMed. Thank you for attending this lecture. Thank you, Dr. Navarro. You may leave this call.
Thank you. Bye.
Thank you,
Bye,
doctor.
everyone. Keep safe.
Thank you,
Thank you,
doctor.
doctor.
Thank you,
Thank you,
doctor.
doc.
Thank you, doctor.